Good afternoon, everyone. Thank you for joining this afternoon webinar. My name is Ryan Gough, and I am the Executive Director of the Partnership to Advance Cardiovascular Health, or PATCH. For those who are unfamiliar, PATCH is a nonprofit dedicated to advancing access and innovation for cardiovascular patients. And we work with our 20 member organizations to lift patient and clinician voices into health policy conversations in states around the country and in Washington, D.C. And we've been doing that work since 2016. I want to thank, first of all, Liz Goldstein and the team at the AC Forum for co-hosting this webinar with us. And we are sincerely grateful for your partnership, Liz, and grateful to the board and your guys' fantastic team. We wanted to hold this webinar today because we're going to discuss one of the most significant changes to Medicare that we've seen in the last 15 to 20 years and the implications it might have for your patients. Despite some major changes in how the government covers medications, we think that what you're going to hear today is surprising and disconcerting. But we also think that and believe that with steadfast advocacy, it doesn't have to be what it is. So to that point, we have some advocacy action items at the bottom of the discussion. So please hang on for those so you can get involved in this effort. We promise to keep this webinar to about 30 minutes because we know it's everyone's lunchtime today. So to get us started, I wanted to introduce two panelists who are going to talk us through the issue at hand. I'm excited to have someone that I'm sure many of you are familiar with, Dr. Geoff Barnes, and then also Dr. Bill Smith. Dr. Barnes is a cardiologist and vascular medicine specialist who serves as the program director for the University of Michigan Vascular Medicine Fellowship Training Program. His research, which is funded by the NIH, the Agency for Healthcare Research and Quality, and Blue Cross Blue Shield Michigan, focuses on developing antithrombotic stewardship efforts to improve the care of patients. He also serves, as many of you know, as the current president of the AC Forum. Thank you, Geoff, for being here.
Thanks, Ryan. It's great to be here.
Dr. Bill Smith is our second panelist. He's a senior fellow and director of the Pioneer Life Sciences Initiative at the Pioneer Institute in Boston, Massachusetts. Dr. Smith has 25 years of experience in government and in corporate roles. His career includes senior staff positions for leadership on Capitol Hill, the White House, and National Drug Control Policy, and the Massachusetts Governor's Office, where he served under Governors Weld and Cellucci. He has also served in several corporate roles to major pharmaceutical, biotech, and medical device companies. And Bill, thank you so much for being here.
My pleasure.
So we spoke just before we started the webinar, and we were joking that it's Friday, and so that gives me license to call these guys by their first names, we've determined. So you'll hear me refer to these guys as Geoff and Bill throughout this webinar, and I thank you guys for that. So what this discussion is largely about, and we'll circle back on this at the end, is ensuring that the policies passed by Congress actually benefit the people who need treatment. That is what this is about at the end of the day. But what we're going to discuss, and Bill, I want you to pop in here, are some of the major changes that we've seen under the Inflation Reduction Act, which was passed in 2022 for Medicare, and kind of table set for us why what we are seeing with the policy, and then we'll talk about the implications of the policy.
Yeah, the IRA was a very complicated bill. It was 1,500 pages, and there were a lot of provisions involving Medicare Part D, and some of them were worthy provisions. So for example, the bill capped out-of-pocket costs at $2,000, so patients can't pay more than $2,000. That helps millions of patients, but it's only about 8 or 9% of patients that reach that cap. So it's helping 8 or 9% of patients, which is a good thing. They also have smoothed out-of-pocket costs. Well, what do I mean by that? A lot of patients pay the majority of their out-of-pocket costs early in the year because they're trying to meet a deductible or something. So the bill spreads that out over 12 months, making it a little easier for patients in the beginning of the year. It caps premiums, although that's a little deceptive. It caps the base premium, and the base premium is just one factor in the formula. It capped it at 6%. Your Part D premiums could grow more than 6% or less. So the premium increase is not straightforward. And the most famous provision, of course, that we're going to talk about a little later is it caps the price of medicines in the Part D program. It started out with 10 popular drugs, and I'm glad we're talking about those drugs today because the first 10 drugs were heavy on cardiovascular drugs and diabetes drugs, which many CV patients take. So, but the caps in the price, surprisingly, is not going to work out that well for patients, in my view. So we can talk about that later.
So just to emphasize here, and Bill, tell me if I'm wrong, but I think you can think of what we've saw with the Inflation Reduction Act as two kind of major changes. One, this kind of Part D restructure that you're talking about. So we have these out-of-pocket maxes that were put in place for the first time ever. We have the smoothing mechanism that was put in place. We have the premium increase caps. So that's kind of one thing. And those are patient-centered reforms that a lot of patient advocacy groups, including ours, have really advocated for a long time for Part D beneficiaries. And then we have a separate thing, which is this cap on the cost of medicine, or the drug price negotiation program that is now given that authority to Medicare Part D.
Yes.
Okay.
Yes. And let me just also say that as part of the restructuring, they restructured who pays for this. The Part D program was paid for by three sources: drug companies, government, and the health plans, obviously. And they kind of rejiggered that, and health plans are going to pick up more of the costs, which could have long-term implications for patient access.
So, Geoff, can you explain? So, I mean, I think that we've been through an inflationary period, and there's no question that every dollar that is taken out of someone's pocketbook is felt more now than it probably ever has been for many Americans. Can you explain, from your perspective and your peers' perspective, how, these changes around the Medicare restructure actually could help your patients, and speak to like the affordability concerns that you hear from patients today?
Yeah, it's a great question. I remember when we first heard about this bill being put together, and of course, when it was finally signed into law, there was a lot of enthusiasm. When I talked to other physicians, other healthcare prescribers, many of the pharmacists and nurses that I work with, this idea that we were actually going to finally help deal with the high cost of many medications, which is a huge barrier for a lot of our patients, that was really welcome news. People were excited because we hear all the time from patients, well, I don't know if I can afford that. I'm not sure if my insurance is going to cover it. Well, I take so many medications, one more that's added on, that's $30 a month, $50 a month, something like that. That can break the bank for many patients. And so this concept of capping out-of-pocket max and lowering the overall price of the drug was something that people were really excited about. Of course, the reality is what we're about to face, and that's what we need to be prepared for.
So, and talk to us too, Geoff. Like, so, Dr. Smith, you mentioned briefly there that, you know, 10 of these medications there were 10 medications that were chosen initially, and the majority of those are cardiovascular medications. And we're talking about Medicare, Geoff. So,
Mhm.
um, help us understand, and many on the line probably get this already, but can you just put a finer point on it for us, like what we're talking about when we're restructuring Medicare? Like, we're really impacting the cardiovascular community uniquely. Can you help us understand that?
Yeah, no, you're absolutely right. When we think about the typical Medicare patient, we're talking about somebody 65 or older, right? Well, that is the typical cardiovascular patient. These are diseases that tend to develop as we age, and so they become far more common in folks who are 65, 70, 75. I'm talking about really common things like coronary artery disease, right? Having a history of a heart attack or blockages in those heart arteries. I'm talking about things like high cholesterol, high blood pressure, and of course, atrial fibrillation, a heart arrhythmia that puts you at risk for stroke, right? These are really common conditions. They tend to impact older adults far more often than younger adults. And so that Medicare population is exactly the population who's dealing with these conditions and all the medicines that we use to manage them.
Yeah, I mean, and I think one stat I've read is that 42% of Part D beneficiaries suffer from at least one cardiovascular condition. So I think it's fair to say that, you are uniquely impacting the cardiovascular community when you're tinkering with, Part D benefits and the design.
Absolutely. And these are conditions that often require multiple medicines. So that cost and pill burden goes up as well. You're 100% right.
So, Bill, Geoff mentioned just a moment ago that, I think that there was a lot of enthusiasm for what we were seeing with the Inflation Reduction Act from a lot of folks in the prescriber community and in the patient community initially. And just setting aside the debate of whether or not, drug price negotiations and price capping is a good idea, we're dealing with the environment that we're in and the environment that patients are in. So this is the reality, and the current administration doesn't look like it's going to change this at all. So this is the ecosystem that we are living in. But for the common patient or the typical voter, if you hear that Part D medications are going to be capped or the cost is going to be capped, your assumption would be, well, great, my medication costs are going to come down. But you've done some research at the Pioneer Institute, and I was hoping that you could explain to our audience what we're actually seeing, what your data shows.
Yeah, for the drugs that are subject to price controls, what we're seeing is a vast rise in the out-of-pocket costs that our patients are responsible for. Now, that sounds completely counterintuitive. You push down the price, how could out-of-pocket costs grow? And you have to understand something about the pharmaceutical marketplace to understand this. Let me use a specific example, Eliquis, which is 4 million Medicare patients. I assume, I'll defer to Geoff, but I assume it's a good drug since 4 million patients take it. It had a list price last year of about $520. Now, under the pharmaceutical marketing practices, the Bristol Myers Squibb, the maker of that drug, probably paid a $200 rebate for every prescription. And the rebate goes to the PBM and it goes ultimately to the health plan. And what does that money do? The money makes it easier for the patients to access the drug so that you get lower out-of-pocket costs. You might not have prior authorization. It's easier for the patient to get the drug. And that's what the rebate dollars do. It's like protection money that drug makers pay to make it easier to access. Well, the government pushed down the price from $520 to $230. And you might say, well, that's great. But what happens is the rebate money also declines. So at a $200 rebate with 4 million patients in Medicare on Eliquis, that's $800 million a month that went to PBMs and health plans just for this one drug. That's what's at stake here. And if you push down the price and you push down the rebate, say the rebate is not $200, it's only $100, that means that you're only giving rebate revenue of $400 million to the PBMs. So the PBMs are losing $400 million somewhere, and they have to make it up. And one way to make it up, and our data is demonstrating this is what they're doing, is raise out-of-pocket costs. And the out-of-pocket costs for Eliquis have grown from an average of $74.51 to $98.42. And we're seeing that across the board with these first 10 drugs. Their out-of-pocket costs are growing, largely because PBMs are probably losing rebate revenue due to the declining price. So my advice to policymakers is, if they're going to push down the price, they got to do something about PBMs and rebate contracting, because under the current system, that's going to make it more difficult for patients to get these drugs.
So, Bill, can you back up a little bit and help people understand how you guys actually came to these numbers, looking at these first cardiovascular medications and like what you're actually seeing for the patient? Like how high are those out-of-pocket costs increasing for beneficiaries in 2025?
It varies, but they're growing by about, on average, 32%. They grew on average on 32% from the first quarter of 2024 to the first quarter of 2025. And what we did is we just went out and bought the out-of-pocket data from 4 of the largest PBMs that make up 87% of the market for Part D. They manage 80% of the benefit. And we went out and purchased it. And the data is real-world data. It's not theorization. It's not speculation. It's real-world data from claims data. And the rises are significant, 32% on average for those first 9 drugs, 10 drugs. We still only studied 9 drugs, let me say that, because one drug was an insulin, And insulin, they set a price of $35 in the bill. So we couldn't really study the changes in out-of-pocket costs for insulin because it's fixed.
And so, Dr. Smith, so you all went out and actually purchased the formulary data. You're looking at the actual out-of-pocket costs that patients are experiencing now in 2025. One question I have for you, and I should have mentioned this at the outset, folks, but if you have a question, please put it in the Q&A and we'll get to them as we can. Is, you know, these price caps don't go into effect for a couple years. So why are we seeing this happen now? Can you explain that?
Well, the PBMs are anticipating they're going to have revenue losses, and the first 10 drugs, the prices take effect on the first of the year. So yes, it's pushed out from the time they named these 10 drugs. It was a couple years before the prices actually took effect.
Right.
But we're anticipating that the PBMs are trying to make up for their revenue loss, which is going to happen.
Great. So, so the bottom line is that patients' costs are going up. We're seeing that now, despite these price caps. That's the bottom line.
That's the bottom line. It's counterintuitive, but that's the bottom line. And
Ryan,
it's because of the way the pharmaceutical markets work.
Yep. Yeah,
Ryan,
Geoff.
can I jump in here? You know, one of the things when we were talking with Bill that just struck me, and I think it highlights this point so strong, is that $2,000 cap, right? I think I certainly had this sense that many patients were exceeding that, and so this was going to really bring it down. But with only 8 or 9% of people reaching it, that means there's a huge opportunity for these patients to come up to that level of the cap, but then still stay under it. And I think that's where we're seeing this out-of-pocket growth. If last year you only had $800 in out-of-pocket cost, well, now that could grow to $1,500 and you're still under the cap, right? And that's a lot of the difference that I think we're seeing.
That's exactly right. And that's what we anticipate, that people that are under the cap are going to pay more out of pocket until they reach the cap.
Yeah. And I think I just want to mention that, you know, you mentioned apixaban there, or Eliquis. We're also seeing this for rivaroxaban or Xarelto, and there are 3 other medications that are in the CV category. There are 2 other diabetes medications that cardiologists probably already also prescribe that we're seeing this, but for this audience is those 2.
Yeah, the average out-of-pocket cost for Entresto grew from $69 to $86. For Xarelto, it went from $85 to $105. So we're seeing that across the portfolio of drugs.
So Geoff, talk to us a little bit about as the clinical implications as these out-of-pocket costs go up. So I know that there's been some research that's been done on this around anticoagulants in particular. So can you talk to us about, like, we see, I think what's so shocking is, like, if there is actual data to show that if costs rise on these specific medications, something happens. Can you explain that?
You're absolutely right. There's a lot of data to show that as the out-of-pocket cost goes up, patients begin to ration their own care and they start to cut back. I mean, anecdotally, I can tell you about several patients who say, well, I only take my pill once a day rather than twice a day, or I'm going to do it every other day, or I'm going to cut it in half because I can't afford to do it all the time. You know, when you talk about sort of the research, my good friend Steve Deitelsweig, he led an analysis looking at what happened when we changed the tiering level. So when a drug goes to a higher tier level, so it costs more out of pocket, they saw that up to 30% of patients actually stopped their drug when that happened, right? So it's a really real effect. And for these drugs, we're talking about life-saving medications, preventing stroke, preventing, you know, life-threatening pulmonary embolism, managing diabetes so that your cardiovascular risk and your coronary risk doesn't increase. So there's really real consequences when these prices go up. Patients stop taking their medications.
Absolutely. And I'll just, you know, I want to mention, Geoff, and I'd welcome your thoughts on this too. I mean, we're in a budget conscious environment in Washington, as I think everyone's aware. And there's a lot of discussion about cost saving. But there's even research that's been shown that in Medicare populations, that if you get folks on therapy early enough and actually pursue prevention, you can save Medicare cost over time, and that's specifically with cardiovascular medications. And so this seems almost counterintuitive
Yeah,
to not only the budget, but also health.
I mean, you're right. This has been an amazing last couple decades in the landscape of cardiovascular care. And the new, pharmaceutical therapies we have can dramatically impact the outcomes patients are experiencing. And so Medicare has seen actually a decline in overall growth of costs. So yes, it's still expensive, but it's not growing as rapidly as it was before. And we think that somewhere around half of that can be attributed to a reduction in the growth of cost in cardiovascular care. I mean, just think about an example of a stroke and all of the expenses that go along with that, or somebody who has a heart attack, or a really life-threatening pulmonary embolism. When you can prevent that with good medical therapy, and you can avoid all of that cost of a surgical procedure, an ICU stay, a long hospital visit, all the doctor's appointments afterwards, that is significant, and that's what we're seeing.
Thank you. Yeah, agreed completely. So one last question before we get into the larger context, and the Q&A folks are already pointing out some of the larger context here because we have a smart audience. So Bill and Geoff, I mean, we've talked about, if you want to keep people off of therapy, or if you want to contain costs, one way is to increase out of pocket, which is what we've been talking about. The other way is to implement new utilization management. And so, Bill, I was hoping that you could talk a little bit about, prior authorization, non-medical switching, step therapy, what you guys are kind of looking at the Pioneer Institute to see how that's being implemented as well.
Yeah, our expectation is utilization management is not going to take off until these prices actually take effect at the beginning of the year.
Mm.
We're hearing anecdotal evidence that patients are being switched off Eliquis, for example, to warfarin and other cheaper agents or more expensive agents so they can get rebates. We're going to track this very carefully every year, and we're going to find out whether there's a spike in utilization management. I don't see how there is not going to be a spike in utilization management, because the health plans and PBMs are going to pick up much more of the costs of Part D. And there are all sorts of freebies in there for seniors, some of which I'm in favor of. Free vaccines and lower premium caps, out-of-pocket caps. Those things are going to be a burden to the finances of the health plans and the PBMs. And so utilization management is one thing they can do to deal with that.
Geoff, can you speak to the challenge as a cardiologist?
Oh my goodness. I think anyone in this audience who is a clinician really has felt the challenge of utilization management, of tiering, of prior authorizations. It adds so much administrative burden to the work we have to do. In the ideal world, I see a patient in clinic, we have a really good physician-patient discussion. We decide what's the right medicine for that patient. I go ahead and prescribe it, and they can go to the pharmacy that same day and get their medication. And that's the way the system should work. But with utilization management and with prior authorization, I sometimes have to ask my pharmacy colleagues to check on all the different costs. Then I submit it and it gets bounced back to me and it tells me, nope, I have to, try 2 other drugs first before I can get there. Or I have to fill out a big long form and submit it and see if it's going to get approved. That just adds delays. And those delays are not only burden for the staff, right? We have entire teams of people who we employ just to manage that paperwork, but it's a huge burden for the patient, who now has to say, well, I took time off to go to the doctor and to visit the pharmacy. Now I have to go back later. I have to keep track and make sure my doctor's office is filling out the forms at the right time, sending them in, answering these forms. No wonder patients just stop taking their drugs, right? These are significant barriers that get in the way. And for many patients, it's a barrier that's just too great to overcome.
I'll just add to that. For any clinician or prescriber on the line, as I want you to know that there's actually data to show that there was a study done just a couple years ago that looked at 12 different disease states and looked at the increase in prior authorization and step therapy protocols in each disease state. And cardiovascular disease blows everybody else away.
Mhm.
There's been an enormous increase. And so if you are feeling this in your practice, I just want to validate that is true in the data. But for the purposes of this program, what I'm hearing from Bill is that there are anecdotes of this kind of switching or increased prior auth, but it's something that we'll probably see in the next year and something to keep our eyes on.
Yeah, and one thing to be aware of is a lot of this is due to rebate contracting. So in rebate contracting, a PBM can promise a drug maker a certain market share. Say we're going to give you 30% of the anticoagulant market. And in order to make that market share goal, they might put a prior auth on the other drugs and make it harder for physicians to get those prescriptions approved. And rebate contracting is at the root of a lot of these access problems, in my view.
So that's a good bridge, Bill, to some questions that we've already gotten in the chat that I'm just going to encapsulate into a couple questions here. As I mentioned at the top of this discussion, everybody, what this is largely about for us as a patient advocacy organization is ensuring that the policies that Congress passes actually benefit the people that need these therapies. That's what we're in this for, right? And so, Part D restructure, we champion many parts of this. And we think that this law can work, but there are things that have to happen in order to make sure that it works for the people it's intended to work for. And so, Geoff, talk to us real quickly about, I know AC Forum has done a lot in stewardship, and you all held your summit in DC. You've pulled together, Medicare and many other agencies in Washington to talk about stewardship. I know this is important to your community. Talk to us about how this conversation applies to stewardship or vice versa.
No, this is absolutely a component of stewardship, right? At its core, antithrombotic stewardship is about creating systems that help patients get the safest and most effective therapy for them. And sometimes that's a matter of figuring out what's the right drug, what's the right dose, making sure they're not taking an interacting drug. Those are really important stewardship efforts. But another big piece of this is, can the patient afford and actually pick up the drug so they're taking it every day or twice a day or whatever the schedule is? And that is largely driven by the cost and the burdens between the point of prescription and actually getting that bottle of medicine in their hand. And so stewardship efforts to streamline this, to understand these barriers and to help advocate for our patients, I think is a really important piece.
And thank you, Geoff and Bill. So let's kind of the boogeyman, that's over the top of all this is one question someone had in the chat was, is the root problem insufficient regulation of PBMs? And I want to ask you if you could comment on how this conversation kind of fits in the broader discussion that's being had right now, even now in DC around PBM reform.
Yeah, I know President Trump has put forward a most favored nation pricing scheme where he would set prices based on the prices in other developed countries. And his goal would be to push down prices even lower than the IRA did. The problem with that is unless you have some kind of PBM reform and you get at this rebate contracting problem, patients could pay even more out of pocket with lower prices. That's the counterintuitive part of this. And that's just the way it works. That's just the way the pharmaceutical marketplace works. Rebates make easy access for patients, lower out-of-pocket costs. And when you push down the price, you push down the rebate revenue.
This is just the ecosystem that we're in. We have to change that.
Yes, they'd have to reform PBMs before they push down the prices significantly.
Geoff, just to round us out here before I get to the action items, it's how do you think that the clinician community understands this? I mean, I would say the answer is probably no, but I mean, it's really disconcerting. I mean, that this entity exists that I don't think a lot of people understand very well, that is preventing these cost savings from being passed on.
You're absolutely right. And I can say, right, as a practicing clinician, it was only a couple years ago that I even heard the term PBM or pharmacy benefits manager. And so when I talk to my colleagues, most of them have never heard of this, right? We have this conceptualization that a patient has insurance. The insurance company pays for the medicines at the pharmacy and everything works. But in reality, there are these organizations in the middle of that process that are largely regulating it. We need to help educate people about this to understand how that fits. And once you know that, then you start to understand why the goal of the IRA, which was to cap out-of-pocket costs and lower the overall cost of a drug, why you may see this counterintuitive rise in what patients are actually paying, because there are these other steps in the system that are not necessarily being targeted right now. And so they're able to sort of squeeze things. We've got to get people to have a better understanding, shine more light on this, so then we're aware of the situation and we can advocate for our patients. Because that's at the end of the day, the most important thing is patients get the medications they need to live healthy lives.
Absolutely. I'll just say before I get to the advocacy asks here, I mean, I feel very strongly about this issue because what we have is a law that is intended to benefit people at a time when people need that help.
Mm-hmm.
And I do not think that, well, it's true. I mean, Bill is showing that it's that the cost savings are not going to be passed on. And I will say, there's kind of two methods for advocacy for everyone that's on the call. The first is to CMS itself. And Bill, you may be able to comment on this a little bit, but CMS puts out bids or accepts bids from the different plans. And so the plans come to them and say, this is what our formulary structure is going to be this year. And so one thing that we've talked about is we have a letter that has gone in that several organizations have signed on to, several clinicians have signed on to, including Dr. Barnes, saying to CMS, hey, you need to be aware of this data and you need to make sure that you're keeping the plans and the PB and their PBMs accountable. But Bill, can you speak just real quickly about how this process works at CMS and
Yeah, we're trying very hard to get into CMS to present our data because they should be aware that patients are paying a lot more out of pocket for the MFP drugs, the drugs that are supposed to be more affordable, and they're now less affordable. So yes, the CMS does approve the formularies, but you got to understand they don't get it granular enough necessarily to follow out-of-pocket costs. They may look at tiers, but within a tier, you can have a out-of-pocket cost of $200, or you can have an out-of-pocket cost of zero. So CMS may not get this granular when they approve these formularies, and we want them to get this granular. If we could
right,
get it, they can get it.
100%? So I mentioned at the just a moment ago that we have this letter that has gone into CMS asking for a meeting to talk about these problems, to highlight this data, to implore them to look at the out-of-pocket cost increases that patients are seeing, and that is one kind of piece of advocacy that's been done to this point. I will say though that kind of piggybacking on what Bill said there, uh, the Congress, their constituents are patients, and they are the ones that are going to be seeing the out-of-pocket costs increase. So therefore, effective advocacy really can be also pushed towards members of Congress who are going to see whose constituents or patients are seeing these increase in out-of-pocket costs. So on the screen, what you're seeing is a slide that we've put together. We have a letter desk that we've put together, or a voter voice, and you can just take your phone and take a picture of that QR code. It'll take you to a website that we have that will allow you to just put in your information. It'll automatically link you to your federal representatives, and you can send through a personalized message to them to say, you need to take a look at this. And so I would encourage everyone to do that and to share that with your colleagues. You can also go to our website and find it there as well, but we wanted to make it easy with the QR code today. The second thing I would ask is that we have the data from Pioneer Institute and Bill and others. Actually, I think USC Schaefer came out with a study this week that backs up what Bill is saying as well. Well, we need some anecdotes. We know that data is something that legislators need, but they also need the human story. And so for the clinicians and the prescribers on the call, if you hear of your patients on rivaroxaban, apixaban, or any of these other MFP medications, and their out-of-pocket costs are going up, or they're being non-medically switched, or you're having to go through a prior auth that you've never had to do before for this patient, we need to know that. And so please email us or get in touch with Liz, and we would love to talk to that patient and see if we can plug them into advocacy. The last thing is you can join our mailing list at advancedcardiohealth.org, where we'll give you updates on what we're doing here. And I'll just give you quickly that there are several things that are coming out to support this advocacy, including an explainer video of this very complicated topic, some graphics that you can post and share, and fact sheet as well. And I know Liz and the AC Forum team will be sending those around after the call. So wanted to just share those things as well. So there is something to actually do here, and we think that that's very important. And as I said at the very beginning, unless we actually, I think that we can actually make a difference here if we have folks engage. And so we want to invite you all to please do that. So with that, Dr. Smith, Dr. Barnes, I'd invite you to give last couple comments here before we close out.
Well, let me put in a plug for our IRA research. You can go to pioneerinstitute.org. Under healthcare research, you'll see the IRA, and you can pull up all the out-of-pocket data on all of these drugs by PBM and by average. It's an interesting tool that we created because we want to get the data out there.
Thank you.
Yeah, I'll just close by saying this is really complicated stuff, right? These are complex systems with lots of players. But at the end of the day, what drives me and what I know drives so many of my colleagues on this call is about making sure our patients can get these life-saving and life-preserving medications. And we need to make sure that that's affordable and that they have access to the best therapies that they and their clinicians are able to pick together. And so helping to share the story, helping to advocate for your patients, this is a great opportunity to do that.
Thank you, Geoff. Thank you, Bill. We appreciate you all for joining today. Thanks I hope everyone suffered the heat okay this week. And hope everyone has a great weekend and goes and has a fantastic July 4th holiday. So thank you, Geoff. Thank you, Bill. Please follow us at advancedcardiohealth.org, and we will be in touch with other advocacy asks, everyone. Thank you so much. Take care.
Thank you, Ryan.